Good afternoon, and welcome to the LaHIMSS Fall Lunch and Learn series. Today we have Dr. Johnson talking about um, nursing informatics and some other good stuff. But before we get started and I introduce her, I'm going to go ahead and do a plug on our upcoming LaHIMSS events. Coming up on Friday, October 14th, we'll have an event in New Orleans, a Rock and Bowl, and on October 27th, we'll also have a Rock and Bowl event. And we're encouraging members to participate and come out and bowl with the board and hang out and eat and have a good time. Also, in this fall in November, we're having the GC3 Gulf Coast Chapters LaHIMSS Conference. And that's a collaboration between Mississippi, Alabama, and Louisiana LaHIMSS chapters. It's here in Baton Rouge this year. Please register and come and hang out and network and learn some new stuff. It's exciting stuff. You can actually sign up and register on our website, gc3conference.com. I have it displayed here. It has you can book your hotel and attend and register for the conference itself. So without further ado, I'll go ahead. I'll introduce Dr. Charlotte Johnson. Today, she's coming to us. Dr. Johnson has over 35 years of experience in the healthcare industry and in nursing, with the majority of her nursing career aimed at the promotion of musculoskeletal care and the advancements of orthopedic nursing in the regional, state, and national levels. Charlotte has a unique lens in the nursing role in advancing health equity from her volunteer experience at an orthopedic clinic for the uninsured and underinsured in Baton Rouge, Louisiana, prior to the introduction of the Affordable Care Act, with highlighted inequities in care. Her leadership roles in healthcare cover orthopedic program coordination, community outreach, utilization review, case management, nursing professional development, and informatics. She's the author and national speaker on topics related to nursing leadership and professional identity, shared decision-making in osteoarthritis, delirium prevention, remote workforce, and the integration of social determinants of health screening in clinical workflows. She's an adjunct faculty at Fran U and Northwestern State University. She currently serves as System Director for Nursing Informatics, Franciscan Missionaries of Our Lady Health System. In this role, Charlotte is responsible for promoting interoperability of electronic health record and the integration of evidence-based practice in the documentation paths for clinical team using a systemness lens. Charlotte is the board certified in orthopedic nursing and nursing informatics. She currently serves as the immediate past president of the National Association of Orthopedic Nurses, the president of the Gulf Coast chapter of American Nursing Informatics Association, and executive board member of Movement is Life, a 501c3 aimed at eliminating musculoskeletal health disparities in women, African Americans, and Hispanics. So without further ado, please welcome my friend, Dr. Charlotte Johnson.
Thank you, Chris. I really appreciate that. And I'm going to count on you for advancing when I say next on the slides. But the title, thanks. The title is representative, the charting with being crossed out. There's the Future of Nurse report, but charting was a play on in their report around the documentation, documenting or charting a path to health equity. But we know that nurses' role is, really about documenting the assessment. So the play from the informaticist lens is around the mapping, and we can appreciate in informatics, whether it's on the IS or the IT side, the way we embed and link our data is so important to interoperability, and all these things lead to advancing health equity into our future. So next for me. There you go. The Future of Nurse report is about 500 pages long. It's quite extensive. It has like 9 core recommendations and a total of 54 recommendations, specific recommendations. The vision of the report is the achievement of health equity in the U.S. that's built on the strengthened nursing capacity and expertise. And they had some central themes, which included greater health equity and a more diverse workforce. In order to achieve a future path for nursing, the expert committee highlighted areas that nursing is going to face. We need to look at reducing health disparities and promoting equity for all. We're going to be challenged with the rising costs because more equitable care delivery. It's one of the biggest barriers to actually accessing health equity. And the reason for that is there's over 160 million Americans that have at least one chronic disease and/or disability. We're going to need in the next 10 years about advancing and using technology to reach vulnerable populations. Now, we saw this just explode during the pandemic, our capability in the virtual world and how we set up appointments, but it didn't reach our vulnerable population. So that's where we need to go 2.0. So we know we need to use technology. Now we just need to where it reaches, and so that's a lot. It's working with our systems as well, our communities, and because of the broad bandwidth, et cetera. And then we need to place a priority on being patient centric, and I would and patient and family centric. But I would argue that most people or healthcare providers think they are patient centric, but are we really? And do we really ask the right questions? And do we understand the patient and the shoes that they're walking in? And do we have enough empathy to be able to understand their journey? Next. So I want to talk a little bit about, because my goal today, to give you some pearls today, is really to understand, in order to advance health equity and how the nurse informaticist role is really to understand the whys behind it. So I'm going to give you some principles around health and health equity and understanding this lens, and so that we can, as a group, IS and IT, understand each other's roles, but then challenge each other to be able to actually do it. So, health is a dynamic state of complete physical, mental, spiritual, and social well being, and it's not merely the absence of disease or infirmity. Individual needs a fair and just opportunity to achieve health. And so, health is not an absence of disease or infirmity, and health is not health care. Health equity is the attainment of the highest level of health for all people, and achieving health equity requires valuing everyone equally. And to achieve health equity really requires removing obstacles to health. And that's the shoes that I was talking about. Everyone's walking in a different pair of shoes. And this could include poverty as a barrier, discrimination, and the consequences of that, which includes powerlessness and a lack of access to good jobs and fair pay and quality education and housing and safe environments and healthcare. All these things lend itself to health equity. It can be measured by reducing and hopefully eliminating disparities. So if you think about health equity, think about it's the process, and health disparity is actually the outcome. Next. So a one-size-fits-all approach doesn't matter. I love this image from Robert Wood Johnson, because I can give everybody a bicycle, right? And that's being equal. I can give everybody a bicycle. But if it's not the right bicycle for the individual, can they really cycle at their best and achieve the goals that they need to? Or can they even get on the bike, right? So that's really the biggest difference about being equal and equity. Next. Social determinants of health, or the social risk and the economic and social conditions that influence individual and group statuses, they are the conditions where people born, they live, they work, they play, and they age. It makes up both people where their age, so their, the genetic side, their age, their gender, and it's also about what people do, which is their health behaviors and their lifestyle. Medical care is extremely important, and we would all argue, because that's the business that we're in, that it's the most important. But actually, when it comes to health, it only attributes to about 20% of someone's health. And that's mainly because when we enter into someone's health, it's in their disease state or an injury state. So it's kind of episodic versus really looking at it a wellness and a prevention lens. And so really it's the things like school systems and affordability of housing and good jobs and fair wages and safe neighborhoods, these non-medical conditions that actually make up someone's health status. So to address health care disparities in a hospital, we have to be able to look at these and measure these. CMS is actually proposing 3 health equity focused measures that hospitals will begin to attest to in inpatient quality reporting. There are second and third measures that address documenting and capturing the screening of these health and social needs. Also then pulling in, looking at claims data. So looking at food insecurity and housing instability and transportation and utilities, etc. All these things through looking at claims. Next. So when it comes to good health, our zip code can be more important than our genetic code. Significant life expectancy gaps persist across many areas in the United States, across our cities and our towns and our communities. The latest estimates of life expectancy at the census level reveal there's a lot of differences among communities. So what I have here is actually just our zip codes from the areas where our ministry, our healthcare ministry that I work in, Franciscan Missionaries of Our Lady Health System, we're in both Louisiana and Mississippi. And I took the zip codes where our facilities reside, and you can see that there's a big difference at the state and the national level. You can see here that in Ascension and Lafayette, we've got smiley faces. We're higher than the national level, but then our counterparts are not. And then you look in Jackson, which is Hinds County, they're definitely lower than the state itself is lower than the national average. But you look in Washington, which is parishes, right? Washington Parish, which is where Bogalusa resides. We have one of our facilities, Our Lady of Angels, is in this community, and it is the least of these. It's like 60 out of 64 in the parishes for life expectancy. Well, actually, for longevity, it's ranked last. And from the quality of life, it's ranked like 60 out of 64. So, if you driving through Bogalusa to get to the hospital, you're going to see more dialysis centers than grocery stores. I mean, it's ravished with poverty. There's not a lot of economic opportunities. Their school systems are in the failing class. And so this is what determines someone's health. And so we can deliver great care at our facility, but unless we're changing those dynamics around in that community, we're going to be episodic in the care. Next. So many factors influence our length and quality of life. And this is a great illustration from the County Health Rankings model. It shows how each factor impacts individual and community health. And within the model, we can see that the percentage of influence of each health factor. So if you like health behavior, so this is our lifestyle, right? So it's about 30% of our overall quality of life and our length of life. Clinical care, I mentioned, I told you what we do, our healthcare business, we're only capturing about 20% of someone's health. But then we look at, in the physical environment's about 10. So the biggest bucket is the social and economic factors. And these social and economic factors are education, employment, income, family and social support, and community safety. So I'm just going to give you little pearls about the why these are so important to health. In education, studies indicate it has a close relationship with health. The more educated, the better health outcomes. Every additional year of schooling is associated with better health and health behaviors. The more educated people are, they smoke less, drink less, weigh less, have lower mortality rates, have lower obesity and heart disease prevalence. On average, women who earn a bachelor's degree live over 8 years longer than someone without a high school education. So let's talk about economics. That's our employment. Adults on average spend over half of their waking hours in the workspace, which is in itself impacts health. Work conditions vary across disciplines, right? There's more risk in certain different fields. Employee compensations delivered you can get by wage and by benefits, right? Which impacts not only the individual's health, but then the dependent's health as well as the health of the workforce. Individuals without insurance are more likely to delay medical care and, as a result, have higher hospitalization rates, longer hospital stays, and worse health outcomes. Higher prevalence of substance abuse disorders, chronic disease, mental health problems, and disability are associated with poverty. So incrementally, people with higher income, right, they may live longer because we have more capital to spend on goods and services, right, such as education and good nutritious food, and I have a safe place to live, and I have accessible neighborhoods. And so socioeconomic status dictate what choices individuals have and how they, and in turn, may behave. family and social support. Social isolation is defined as the lack of meaningful contact. And let me just add, being married does not mean you have a good social contact. That's in the literature. So it's one of the screening things that we do. It's not just that they're married. We want them to answer those type of questions, because just having someone linked to you by marriage doesn't mean it's supportive. The quantity and quality of social support or relationships are linked with numerous health outcomes, including lower rates of morbidity and mortality and improved mental health. And then the community setting. So crime and violence or exposures within communities have short and long-term health effects. The prevalence of violence is higher in areas of concentrated poverty. The biological and mental health effects of violence impact the incidence of cardiovascular disease, premature mortality, depression, anxiety, post-traumatic stress disorder, and suicide. So if I live in a safe area, I am likely to be able to participate in physical activity such as walking. So where people have neighborhood safety fears, so if I'm scared about the crime in my area, I'm scared about where I live, they have higher levels of obesity. And then lastly, I'm going to do food insecurity, because this is an important one. Food is considered a household resource, and it's not measured as an individual item. So a household is considered food insecure if they didn't have enough money to be or resources for food. Food insecurity is linked to a higher chance of chronic disease and has a stronger association to chronic disease than income. And disability is a contributing factor to food insecurity. Next. So I'm using Washington Parish, which is where Bogalusa and Our Lady of Angels resides, show the impact of disparities. So in the social and economic factors on health outcomes, you can see how they're ranked, again, the least healthiest in our state. They're like 57 out of 64. And again, they have the shortest longevity in our state. Next. And we can't leave New Orleans out, because they made the top 10 list about being stressed out. This was a from Wallet Hub, and they looked at like 180 cities that across 40 key metrics that were determined who copes the best. Well, we flunked. So New Orleans was ranked 7th about being the most stressed out. And I added the little arrow in there because, again, where our ministry is, Jackson is number 12. Next. And one of the things around, let me just say something about stress, because chronic stress affects how individuals' well-being physically and mentally, and those long-term consequences of stress, muscle pain, insomnia, anxiety, high blood pressure, and a weakened immune system. And I think when I think back about the pandemic and how challenging in that space New Orleans was and their COVID exposure, you think about the link with that stress and COVID. So for our use of technology, when we address inequities, this can be done at both individual and structural levels. So nursing at the bedside, the caregivers at the bedside can certainly provide clinical care to improve health, but they can also screen, collect, and document these social determinants of health during the patient's encounter. And because nurses understand the workflows and the care delivery models, they can also provide the level of expertise within informatics to help design, generate, analyze, and apply the data to support health equity initiatives at an individual and population level. And that's where the informaticist role comes in this case. At a structural level, there's some recommendations in the Office of the National Coordinator, the ONC. They have built a nationwide infrastructure just around social determinants of health, and they've been focused on data tagging to assist with data exchange. Some of you may be familiar with the Gravity Project. It was originally funded by the Robert Wood Johnson Foundation, and it was to identify coded data elements and associated value sets that would represent the social determinants of health documentation in the EHRs. The project addresses coding and terminology and the HL7 fires, the APIs, and they've implemented a social determinants of health implementation guide to help payers and providers and facilities. Also, their goal is to ensure that health equity data collaboratives improve the visualization of the data that we extract. I also want to be able to give nurses in the clinical settings not only the responsibility, but the associated resources to innovate and use technology. the expansion of telehealth is just one way about innovation and use of technology to improve disparities. ONC Advancing Standards also looked at they have a precision medicine project, and it's focused on two areas of standards that are real of importance: the mobile health, the sensors, the wearable data. This is all really important. I think, again, how we reach vulnerable populations, and then looking at social determinants of health data. Next. As a community, there's upstream factors such as institutional inequities, laws, policies, and regulations. And sometimes we don't always look at them, that they're barriers or causes of conditions that support health. But one example I'll just use, like at a parish level. So a parish's planning and zoning committee, right? They create standards for your land use and the development, land use and development standards. So one example could be if parish planning zone said, hey, if we're going to have new developments, then at this level to support health, we would require sidewalks that would give people safe places to walk. Or within new developments, there needs to be a designated green space for a activity area. That's just an example. Another example would be budget for funding law enforcement. We don't think about the potential inequities about funding law enforcement, but without it, there's an impact on community safety. So it's important that we support those type of initiatives. Same thing around environmental regulations on emissions. There's around our plants tend to be more poverty areas, and so then they're more prone to having challenges around asthma or COPD or some more respiratory type illnesses. There's midstream factors that might prevent a person from achieving optimal health, which include, again, the individual's social needs. So through the midstream efforts, nurses, this is where we can make an impact, not only nurses at the bedside, but the nursing informatists to help those nurses at the bedside screen for those social risks because of the lack of housing, food access. The nurse can use these data elements to inform referral to governments and community resources. And so there's a lot of efforts now and different third-party vendors, et cetera, that we can integrate to be able to help us link our referrals to care and to be able to give us an outcome-based loop. So you think about things like Find Help, or what used to be called Big Bertha. That's an example of a workflow or an entity that can help do a closed referral loop. So data can be used to highlight needs on the zip codes especially, and then also show accountability for the allocation of resources. And these elements help a hospital address, every 3 years, a hospital has to do mandated community health needs assessment for their tax exemption status. And so really identifying the priorities from a community standard, you can be able to use now this data to look at where the needs are to make the greatest impact on someone's health. And then again, it begins to really help us have an accountability about where we put our dollars into the community to support those initiatives. Historically, social determinants of health data has not been structured in a way or standardized in a way in our EHR platforms to be able to extract it. But now we have these standardization, starting to use validated screening tools, not just questions that we think we need to ask, but questions that are uniformly being asked at a national level that have been validated to be able to drive that we're all measuring apples to apples when we're talking about social determinants of health. And again, that's where ONC's, their implementation guide, has been very helpful with standardization of these pieces, and but also the linkages. So for nursing informaticists, we bridge the gap between data and nursing practice. We understand and know how to communicate the why behind the processes, the implementation of new processes, and then how we can validate that quality data. Next. And I guess with the big commitment pop up, it takes the commitment at all levels within a health system or an organization, because it's a lot of commitment of resources. So social determinants of health are part of our patient's story, right? And for us to deliver holistic nursing, this means we need to learn about the patient's whole story. And so sometimes when we open a chart, all we see are the diagnoses that stare at us, right? Maybe it's obesity, anxiety, depression. But what we don't see are those attributable causes or challenges for that patient to improve their health within those specific diseases. And as a provider or clinician, we all have our implicit bias as a role that plays in the care that we deliver. Each one of us has unconscious bias. We have our own lived experiences and our unique way of how we respond and see things and how we look and stereotype. So it's important that we take a step back, really start to look at what's driving someone's story to their health. So I would have to say, you've probably all been part of a doctor's appointment where they may have told you, hey, I want you to lose weight, or I want you to move more, exercise more. But I bet you no one from a patient-centric lens asked you if you had a way to exercise more, or if you had the funds for healthy foods. You might have showed up there polished. You had insurance, so maybe they're already thinking, oh, this person's in good shape. They don't have a need. But then again, that's where our implicit bias comes in. We didn't ask, so we don't really know. Next. Next, Chris. There you go. Thanks. So before July 2021, our system collected social determinants of health information, but it was part of the patient's story, but it was not captured in a way to inform care or even monitor the documentation, adoption, or compliance of, were we doing it? It's not a required documentation for us to collect it. So screening for it to be done, would need to be done in an intentional way, meaning someone would really need to understand the why, and it's important to be able, and it be maybe a priority for the organization for it to be done. Screening was only accessible using this wheel within the electronic medical record. So from a workflow standpoint, provider or a nurse would be in their normal flow sheet documentation, and if they were going to document something in the social determinants of health manner, they would have to get out of that workflow and go into this wheel. And even if I clicked and answered these questions in the wheel, it didn't populate anywhere else. So within the nursing informaticist world, we looked at the questions for each of the 11 domains, and we did a workflow analysis to determine the patterns of documentation for nursing and our allied health professionals. So our social workers, our physical therapists, and our occupational therapists, to find out there may be places in their workflow that if we embed questions, that it would also improve screening compliance. So we looked at where and at what point in the patient care were the team members actually documenting this evaluation and performing screenings. So for nursing, we matched the social determinants of health screening to questions that were in similar categories within the admission navigator. So even though our questions with social determinants of health are not and still are not required, our admission navigator, us to do an admission assessment within the first 8 hours of someone coming to our facility, is a required element. And so there's not hard stop on the questions, but because we embedded them into the natural workflow and made them priority in the elevation of the question areas and the categories, you can see here that in July when we had it up and running, but no one was doing it because it was in the wheel. And then we started moving these elements, and you can see moving it into the workflow, the progress we made from a compliance standard. Next. So ONC focuses on 4 areas with respect to how health IT can be used to help advance health equity through social determinants of health. They use standards and data, use infrastructure, policy, and implementation. And advancing the use of interoperability of social determinants of health data is important to improve health equity and well-being of all individuals in all communities. ONC works collaboratively with the federal partners as well as stakeholder communities to advance the electronic exchange. So they have put out a guide about the development, dissemination, and the adoption of the standards. They've really worked hard to inform policy development to overcome the challenges around the social determinants of health interoperability and the data use of it. They've worked to support states and local governments as they build the infrastructure for the social determinants of health on the state level, and then driving innovation with the care delivery of health IT. Again, they've put health IT tools out there and then give us standards to integrate these into our workflows. Next. So I applaud HIMSS as well because they've done such a great work working with nursing, especially in the space of innovation. They've highlighted a collaboration with the American Nurse Association, and there's a shared priority on nurse-led innovation. Their first effort started around 2019, and they had the nurse pitch, and it was at a global conference, and they've done it every year since. And it really is designed to increase the voice and opportunity and visibility of nursing as an audience within the digital health ecosystem by advancing a nurse-led and a nurse-developed innovation. So another space that they're that's core to advancing health equity is also around making informatics and innovation part of a core nursing competency. So really working in the academia field around curriculum changes and adoption. There's lots of different now Masters of Health Informatics programs. There's also nursing informatics programs. And so working with those core competencies, also realizing that because there's a change in the nursing workforce, how do we prepare? So now I think we also have an additional lens because, nursing is the largest workforce within the health ecosystem. But we, over the pandemic and through the challenges that we saw with mandates, et cetera, nursing lost about 500,000 of its own, whether it's through early retirement or I'm leaving the profession altogether. This is too much. I can't handle it. And so having our own shortages, we know that there's other collaborative partners that were once removed out of the acute care system and pushed into whether it's long-term care or the provider's offices. Now they're coming back to be partners. So now we're needing to train up our licensed practical nurses with this level of technology because they're going to be extenders and partners in the type of collaborative care that we give at the bedside. So how do we prepare and train our workforce on technology integration? And then, of course, we have that rapid involvement and rapid change in our technology environment. So again, keeping with the latest type of technology integration is important to be at the top of the game and the adaptability. Next. So Martin Luther King, he's attributed to saying that of all the forms of inequality, injustice in health is the most shocking and inhumane. And so this is just a point of reflection because I'm not sure how many really understood around social determinants of health and the impact that it has in the IT and IS space, and maybe bring a different meaning into the job that we do. Next. So if health is built from where we live and learn and work and play, take a water. What? Oh, I'm a joke. What is our role? Sorry, that's ugly. What is our role? Next. Attaining more equitable outcomes. Next. Aligning innovation and data to influence resource allocation. Collecting, sharing, and analyzing data. Improving health decision-making. Thank you. Next. And ensuring that evidence-based practice is integrated into the things that we do into our workflows. Next. So I apologize for that. I'm gonna turn my camera off so you're not seeing it. So in summary, If the achievement of health equity in the U.S. Takes everybody. Nursing is the largest member of the health workforce, but health equity will be built on strengthening our nurse capacity and expertise. Health systems need to structure clinical data so that's collected in a manner to inform care and drive medical decision making. In reality, we know that a lot of the EHR documentation is fragmented and requires manual abstractions. But we have inefficiencies, we have errors, we have missed opportunities. Social determinants of health data may be collected, but it's not available in a meaningful way. So ask yourself, are your organizations, are they poised to just check a box for attestation? Or are they doing something that adds value? As IT and IS experts, we need to ensure the documentation development and build continue to capture defined workflows and that it incorporates discrete data for metrics reporting. And I would have to say, then we need to map our way to health. Next. So I am happy to entertain any questions after I take a sip of water. Okay, I'm good.
Thank you, Dr. Johnson.
Oh gosh, I
Thank you for the
apologize for that.
presentation.
I know, right?
Does anybody have any questions for Charlotte?
I don't have any questions, but I think Charlotte made some very good points in this presentation, and it actually touched me a little bit because having grown up in an area that I would probably now consider to be part in that poverty bracket, I can recall days where when I began my health journey that I'd go visit my grandparents, but I wouldn't take a walk because I felt perhaps the neighborhood wasn't as safe as the one I'm used to walking in. So I think that was very eye-opening.
Thank you, Padrina.
Thank you, Padrina. Does anybody else have any other questions or comments? I really like the bicycle slide.
It does paint a good picture about
does.
understanding being equal, because we all have even our Constitution talks about being equal, but in a lens of equity, it's about removing barriers or understanding the patient's story to help them achieve their best. And so, yeah, it puts it a different perspective because I can give everybody the same thing, but might not meet their need.
Mm-hmm.
And I
Charlotte.
do think unconscious bias, right, to call that out and for us to be aware of our own, because if we never ask the question, we can assume all day long and never really understand the need of the patient.
Absolutely. Absolutely.
Charlotte, what do you think health systems should, the top three things health systems should do? I mean, I think as technologists, we'll make sure they get the records they need and can document determinants of health. But now I think on the health system level, and what three things would you like to see health systems focus on to address this problem?
Well, thank you, Avery. I do think what's important and what we lack is the why. I think a lot of times in health systems and healthcare organizations, we have a lot of initiatives, and the initiatives usually are financial incentives or risk that make us integrate them into practice. So you think about all the things that we do around promoting interoperability. If we probably didn't have CMS with their proposed rules and telling us that we have to attest to them, then likely we would not today have the type of record that we could share with our patients and or share with our other providers. So, and sometimes we just say it's because, but I think helping our end users understand the why would help the screening. So I think the why needs to go at the community level so that they understand and be empowered as well, but that they also the why at the nurse and the provider level. Again, how much do our providers really understand the cost of poverty? And when we look, and I use those, obesity, anxiety, and depression as an example, because if you open my family member's chart, that's what you would see. You would see those three things, and those three things have actually interfered with their care because of bias. And so I think if we would really allow, and I think we're starting to do the good work especially within our ministry, but helping them understand the why, promoting more around, the use of a electronic medical record at our patients, so that we're having my chart bedside, or whatever platform or vendor you're using as your medical record, a patient portal, really stressing the importance to the patients. If they have barriers to their email because of their age, then how are we having that next level conversation with their caregivers that do have the technology to help them?
Thank you. I think Sport had a question.
Hey, yeah, thanks. This is great. My question is probably more on a more personal in a sense, and what I mean by that. So, as an African American male, and I think about health disparities, maybe you can give me some suggestions on what things I can do personally to help maybe those in my community, my church, family, and friends to overcome this, right? Because they have challenges. Many men don't even want to go to the doctor. So maybe you can give me some pointers on what I can do personally to help those that live near me and around me every day.
Well, I think it first starts with having that, being able to have an open and vulnerable conversation with the people around you, and to be more informed yourself about the inequities that exist, so that we can be champions within our community. I think our faith-based partners play a big role because they're seen as a trusted entity, and we could partner with them to be able to, advocate for, even like thinking about wellness things, like, advocating for healthier foods, or a place to, maybe a walking club within the church, or when you're having your church banquet or whatever, then it's not always necessarily the fried chicken or whatever, so that we can start incorporating healthier behaviors in the conversations. Really have an evaluation where these leaders as well are being more civic minded, and they're playing a role within their own communities. I think we have to get grassroots and be really involved at our community levels in the spaces we are. So if your impact is at your church and your family, that's where I would say, just take the first step, have the open and vulnerable conversations, and be part of the change.
So, thanks.
Well, again, I just thank everyone for the opportunity. So sorry for my ugly choke fest that I was having, but I hope the majority of it was uninterrupted. So, but again, thank you for allowing me to talk about this topic.
Thank you, Charlotte. And it was a wonderful presentation, and thank you for your time. If everybody could also thank you for joining, and don't forget that we have 2 Bowling with the Board sessions in October, and then the GC3 conference in November. So please sign up and join. We appreciate everybody taking their time out of their lunch break on Friday, and look forward to the next Lunch and Learn event. Thank you all.
Thanks, Chris.
Thank you.
Thank you. Bye.